Hello, in this video we will talk about gastrointestinal bleeding. I'm gonna read it from edition 10th of Ghai, page number 325 and chapter of disease of gastrointestinal system and liver. Let's start. Gastrointestinal bleeding. Gastrointestinal bleeding is commonly encountered problem in children. Upper gastrointestinal bleeding is defined as bleeding from the side proximal to the ligament of Treves. When do we call it upper GI bleed? If the bleeding is proximal to the ligament of Treves. Okay. At the level of duodenojejunal flexure, where this ligament of Treves is present, it is present at the level of duodenojejunal flexure, right? So if the bleeding is proximal to this ligament of Treves is that point of which defines that this is the upper GI bleed. We have to remember this ligament of Treves, and lower gastrointestinal bleeding is defined as bleeding from a side distal to this ligament of Treves, right? Lower GI bleed, this distal to the ligament of Treves. Okay. Now coming to first topic, that is this hematemesis. What is hematemesis? It is passage of blood and vomiting and suggests an upper GI site of bleed. The vomitus may be bright red or coffee ground in color. What can be the vomitus color? It can be bright red or coffee ground in color depending upon the severity of hemorrhage and the duration it stayed in contact with the gastric secretion. It depends on what? The color depends on the severity of hemorrhage and the duration it stayed in contact with the gastric secretion, right? And what is melena? Melena is passage of black tarry stools and suggests an upper GI bleed or a small bowel source of bleed, right? And there's something called as the hematochezia. This is the passage of bright red blood in the stools. There's something called hemobilia. This refers to bleeding from a biliary tree, while hemosuccus pancreaticus is bleeding from the pancreas. Okay. Small bowel bleeding can be overt, present with either melena or hematochezia, or occult, present with the iron deficiency anemia and the guaic positive stools. Okay. Obscure GI bleed is used to define patients with source of bleed where the source of bleed is not identified. Fine, that's called as the obscure GI bleed, in which the source of GI bleed is not identified after the upper and the lower endoscopy, small bowel evacuation with the video capsule endoscopy or enteroscopy and radiographic testing. It can be obscure overt or obscure occult. Upper GI bleed. Upper GI bleed is more common and often massive than the lower GI bleed in children. Okay, what is more common in children? This upper GI bleed is more common and that is often massive also than the lower GI bleed comparatively. And most children with upper GI bleed have hematemesis. However, a small portion may also present with just melena or hematochezia. Only a small portion will present with this. Okay, mostly they will present with this hematemesis. The cause of the upper GI bleed vary in different age group as shown in the table. Varices, esophagitis and gastritis are the common causes in the Indian children. What are the most common causes? This varices, esophagitis and the gastritis are the common causes in the Indian children. NSAIDs are an important cause of the upper GI bleed and history of drug intake should always be taken. NSAIDs and history of drug intake should always be taken. Painless passage of the large amount of blood in the vomitus suggests variceal bleeding. If there is large amount of blood, no, then it's variceal bleeding, especially in the presence of splenomegaly. Okay. So this is important for variceal bleeding. If we have to say that a person is having variceal bleeding, then we have to ask in the history about the amount of blood in the vomitus and also palpate for splenomegaly. However, spleen may reduce in size after a bout of massive hematemesis and thus become non-palpable. Okay. In portal hypertension, esophageal varices are the most common cause of the upper GI bleed. In case of portal hypertension, esophageal varices are the most common cause of the upper GI bleed, other being the gastric varices and the portal hypertensive gastropathy and the gastric antral vascular ectasia. Children in the ICU requiring the mechanical ventilation and those with the coagulopathy have an increased risk of upper GI bleed due to the stress related mucosal disease. Okay. So these children who are in the ICU and which require the mechanical ventilation and with coagulopathy, they have an increased risk of this upper GI bleed due to the stress related mucosal disease. Okay, now coming to the management part. Before we look at the management, let's look at this table of the common causes. Common causes of the upper gastrointestinal bleeding. First one is in the neonate and the infant. Let's look at that. First is the swallowed maternal blood. Second one is the esophagitis. Third one is the gastroduodenal erosions and ulcerations. Then sepsis, coagulopathy and stress, hemorrhagic disease of the newborn, esophageal varices, vascular malformations, foreign body impaction, cow milk allergy, gastrointestinal duplication, and tumors like teratoma. And in children more than 2 years, it can be esophagitis, which can be due to reflux medication or infections, gastroduodenal erosion or ulceration, portal hypertension, esophageal gastric varices, and the portal hypertensive gastropathy, sepsis, coagulopathy, and stress, caustic ingestion and Malady Weiss-Dier, IgA vasculitis, vascular malformation, gastric antral vascular ectasia, foreign body impaction, gastroduodenal duplication, hemophilia, hemosuckers and pancreaticus, and tumors, that is leiomyoma, lymphoma, and teratoma. In this image, what we can see is upper GI endoscopy showing esophageal varices in the first one, and in the second one there are large gastric varices. Okay, moving ahead to the management part. The management approach is shown in the figure 12.27. We will read that. General supportive measures include a good venous access, intake output monitoring, oxygen supplementation, and vital charting. Presence of shock or orthostatic changes in the heart rate and blood pressure, increase in the pulse rate by 20 beats per minute, or a decrease in the systolic BP of 10 mm of Hg upon changing the position from supine to sitting suggests significant losses and need of urgent fluid replacement. Blood transfusion should be given to achieve a hemoglobin of 7 gram per dl. Short-term antibiotic prophylaxis, third generation cephalosporin for 7 days, should be given in children with the cirrhosis and variceal bleeding, as it reduces the bacterial infection and mortality. Okay, so this third generation cephalosporin needs to be given in the children with cirrhosis and variceal bleeding. Okay, now coming to the specific treatment. Depends on the patient's condition, cause of the bleed, and expertise of the available personnel. Upper GI endoscopy is extremely useful for evaluating the cause and the site of bleeding and offering therapy. Fine, this upper GI endoscopy is useful in whom? For evaluating the cause and the site of the bleeding and even sometimes offering therapy. Upper GI bleed is broadly classified as variceal and non-variceal for the purpose of management. A combination of pharmacologic and endoscopic therapy is preferred. An early administration of vasoactive drug should be followed by an endoscopic therapy within 12 hours of the bleed. Okay, there should be an endoscopic therapy. Early administration of this vasoactive drug should be followed by endoscopic therapy within 12 hours of the bleed. Now first one we are going to see the management of the variceal bleeding. Okay, administration of somatostatin or octreotide decreases the splanchnic and azygous blood flow, thus reducing the portal pressure. Okay, so if we are suspecting variceal bleeding due to portal hypertension, then we are giving this somatostatin and octreotide, which decreases the splanchnic and the azygous flow, reducing the portal pressure. Both the agents are equally effective. Limited studies in the children have shown control of the variceal bleeding in 70% of the children. Okay, infusion should be given for at least 24 to 48 hours after the bleeding has stopped and should not be discontinued abruptly. Now coming to this, endoscopic sclerotherapy and variceal ligation are the two main methods used to manage the esophageal varices. Okay, if there is esophageal varices, it can be managed with either endoscopic sclerotherapy or variceal ligation. In the endoscopic sclerotherapy, 1 to 3 ml of the sclerosant, which is 1% ethoxysclerol, is injected into each variceal column. Variceal ligation, the second one, is done with a device called as the multiple band ligator. The varical column is sucked into a cylinder attached at the tip of the endoscope, and the band is deployed by pulling the trip wire around the varix. Both the procedures have 90 to 100% efficacy in controlling the acute bleeding, but the varical ligation is preferred due to lesser side effects except in the smaller children in less than 2 years. Following an episode of the varical bleeding, all the patients should receive secondary prophylaxis till the varical eradication to prevent rebleeding. Gastric varices are managed with the endoscopic injection of the tissue adhesive glue, that is N-butyl 2 cyanoacrylate or the isobutyl 2 cyanoacrylate. These agents harden within 20 seconds of the contact with the blood and result in the rapid control of the active bleeding. Fine. So there was something else for management of the esophageal varices, and for the gastric varices they are managed with this N-butyl 2 cyanoacrylate or the isobutyl 2 cyanoacrylate because they work very fast and they help in the rapid control of the active bleeding. Tamponade of the varices is required only when the endoscopic and the pharmacologic measures have failed, which is very rare, and it is done using the Sengstein Blakemore tube. Is a triple lumen tube with the connection to an esophageal balloon, a gastric balloon, and one perforated distal end which helps in the aspiration of the stomach contents. Okay. Now coming to this transjugular intrahepatic photosystemic shunt, that is TIPS, is an interventional radiology technique that establishes a communication between the portal vein. It establishes what? A communication between what? Between the portal vein and the hepatic vein by placing a metallic stent between them. This procedure results in bypassing the liver resistance and consequently decreases the portal pressure. Fine. There is a communication made between the portal vein and the hepatic vein, right? And how is it made? By placing a metallic stent. So what is this procedure doing? It is bypassing the liver resistance and decreasing the portal pressure. So this TIPS is indicated in the refractory acute variceal hemorrhage or bleeding from the ectopic varices. Fine. This is important to know. When is TIPS indicated? In a refractory acute variceal hemorrhage or bleeding from the ectopic varices. It is less invasive, alternate to surgical therapy, and it requires skills and experience in children is limited. Okay. Now coming to the surgical management, is required when the above measures have failed or when the bleeding is from the ectopic varices that cannot be effectively controlled by the endoscopic procedure, then the surgery is required. Surgery can be done either in the form of portocaval shunt, that is selective or non-selective, or devascularization with the esophageal staple transection. Now coming to the non-variceal bleeding. Intravenous proton pump inhibitor should be started in children suspected to have non-variceal upper GI bleed. IV PPIs should be started in children in whom we are suspecting what? This non-variceal upper GI bleed, and high dose infusion of the IV pantoprazole 2 mg per kg, maximum 80 mg loading followed by 0.2 mg per kg per hour infusion and maximum 8 mg per hour, promotes the clot stability and facilitates the hemostasis by raising the intragastric pH. Okay, so in case of any non-variceal bleeding, we have to give high dose infusion of pantoprazole. This is I'm reading it for the first time. This high dose infusion of the IV pantoprazole 2 mg per kg promotes the clot stability and facilitates the hemostasis by raising the intragastric pH. So the infusion can change to oral medication after 72 hours provided there is no rebleeding, and after stabilization an upper GI endoscopy is done for finding the cause and offering the therapy. So this procedure was done only for the stabilization of the children, and later on we need to do the upper GI endoscopy. So we were giving high dose of IV pantoprazole, okay, and which was doing what? Promoting the clot stability and facilitating the hemostasis by what? By raising the intragastric pH. Okay, by what? By raising the intragastric pH. So maximum 80 mg loading dose. Fine. 80 mg loading dose, that means up to 40 kg we are doing it by this 2 mg per kg. and later on we have to start that with the infusion 0.2 mg per kg per hour. This was how we treat patients with non-variceal bleeding. Now first we read about the upper GI bleed and we saw all the causes also. This is something which is left. Approach to a child with upper or lower GI bleed. This is given for both. So let's read it. If a child is presenting with acute gastrointestinal bleeding, what is the general management? Maintain the airway, support the breathing and circulation, insert 2 large bore IV cannulas, hemoglobin coagulation profile and blood group needs to be done, volume replacement with the crystalloids, blood if required, and insert a nasogastric tube, correct coagulopathy, that is vitamin K, fresh frozen plasma, and brief history and a quick physical examination. Fine, these all things needs to be done. Airway, breathing, circulation, IV cannulas, hemoglobin, we need to check, right, that how much blood has been lost and how much is left. We need to check the coagulation profile and the blood group. We need to do this volume replacement with the crystalloids, and blood if required we need to insert an NG tube and correct this if any coagulopathy is present. Vitamin K needs to be given and a brief history and a quick physical assessment. Now coming to this upper GI bleeding, start the octreotide or PPI infusion based on the clinical diagnosis. Upper gastrointestinal endoscopy needs to be done. Fine, and if it's variceal bleeding, continue the octreotide endoscopic therapy by endovascular ligation or the EST and the glue, and there can be even balloon tamponade, tips and surgery. Consider secondary prophylaxis after control of the bleeding, and in non-variceal bleeding, treat as per the cause. Now in case of the lower gastrointestinal bleeding, it is divided into if it's a mild bleeding and the child is stable, and if it's a severe bleeding. Now in the case of mild bleeding and child is stable, plan for investigation and manage according to the clinical suspicion. If you are suspecting interception, ultrasound needs to be done. Signs of colitis present, then stool culture needs to be done, and if persistent, then colonoscopy needs to be done. In case of severe ongoing bleeding from the lower GI, upper GI endoscopy to exclude the upper GI source, colonoscopy, Meckel scan before the colonoscopy if high suspicion, painless maroon colored blood in the young child, and causes found, then treat accordingly, and causes not found, then CT angiography plus minus embolization needs to be done, enteroscopy, surgery plus minus per-op enteroscopy. Now coming to the lower GI bleeding. First let's read the causes of lower GI bleeding in neonates or infants and then in children. First, in neonates, it is most commonly it's colitis. Okay, it can be either infectious colitis or cow milk protein allergy or necrotizing enterocolitis or Hirschsprung's disease or enterocolitis or cytomegalovirus. Now in children more than 2 years of age, it can be infectious colitis or inflammatory bowel disease or tuberculosis, pseudomembranous colitis or cow milk protein allergy, amoebiasis in the cytomegalovirus, neutrophilic colitis, systemic vasculitis, immunodeficiency, and the radiation proctitis. Other causes can be anal fissures, interception, arteriovenous malformation. This one is in neonate or infants, right? Rectal prolapse, Meckel's diverticulum, hemorrhagic disease of the newborn, and then comes the coagulopathy. And in more than 2 years of age, anal fissures, polyp or polyposis syndrome, solitary rectal ulcer syndrome, Meckel's diverticulum, NSAID-induced ulcer, duplication cyst, hemorrhoids, rectal prolapse, IgA vasculitis, rectal varices and the portal colopathy, arteriovenous malformation, coagulopathy, and then comes the leiomyoma or lymphoma. These can be also the causes of lower GI bleeding in more than 2 years of age, children more than 2 years of age. In this picture, it's a colonoscopy showing multiple sessile and pedunculated polyps. We can see these polyps, right? With a child, in a child with the polyposis coli. Now let's read about the lower gastrointestinal bleeding. The causes of the lower gastrointestinal bleeding as per the age is shown in this table that we just read. History and physical examination help narrow down the differential diagnosis. Increased frequency of the stools with blood and mucus with the crampy abdominal pain points towards the colitis. Colitic illness and infectious colitis is by far the most common cause in the children across all the age. So when we have to suspect infectious colitis in a child in which the stools with blood and mucus is present and there is a crampy abdominal pain which points towards the colitic illness. A sick preterm with the abdominal distension and blood in stools, feed intolerance and the systemic instability is likely to have a necrotizing enterocolitis. Fine. In whom we have to suspect this necrotizing enterocolitis? We have to suspect this in a sick preterm with what? There is abdominal distension, blood in the stools, feed intolerance and a systemic instability. Then we have to suspect this necrotizing enterocolitis. Delayed passage of the meconium followed by constipation, abdominal pain and distension is seen in the Hirschsprung's disease. So when we have to suspect Hirschsprung's disease, we already know right, that there is delayed passage of the meconium and there is constipation, there is abdominal pain and distension. Allergic colitis is most often seen in infants who are top feed with the cow milk and present with the loose stools mixed with the blood and anemia. So this allergic colitis, when we have to suspect in infants who are what? Top feed with cow milk and present with the loose stools mixed with the blood and anemia is present. Onset of the bloody diarrhea after antibiotic use suggests pseudomembranous colitis. Okay. So if a child was given antibiotics and then the child started having bloody diarrhea, then it's a case of pseudomembranous colitis. Okay. Moving ahead, presence of the extraintestinal manifestation like aphthous ulcers or joint pains and iritis gives a clue to the diagnosis of inflammatory bowel disease. So when we have to suspect inflammatory bowel disease, when there is extraintestinal manifestation also, right, like aphthous ulcers or joint pain or iritis also. History of painful defecation and passage of the hard stools with the blood streaking of the stools is seen in this anal fissure. We all know anal fissure, if there is blood streaking of the stools is seen, and painful defecation. In a patient with a history of constipation, straining at the stools and digital evacuation, most likely the cause of the bleeding is solitary rectal ulcer syndrome. There is something called rectal ulcer syndrome, and when we have to suspect it, if a patient is having a history of constipation, straining at the stools and digital evacuation, and most likely the cause of bleeding is solitary this rectal ulcer syndrome. Now in intussusception, when we have to suspect intussusception, is characterized by episodes of abdominal pain, vomiting, red currant jelly stools. That is, what is red currant jelly stools? It's mixture of blood, mucus, exudates and stools. Its painless bleeding is seen in this intussusception. No, painless bleeding is seen in this polyps, Meckel's diverticulum, rectal varices, ulcer or vascular anomaly. Fine, this is an important line. Painless bleeding is seen commonly in polyps, Meckel's diverticulum, rectal varices and ulcer or vascular anomaly. Presence of typical cutaneous lesion is seen in the blue rubber blood nevus syndrome, often suggests a diagnosis. Children with the HIV infection or immunosuppression secondary to chemotherapy can develop CMV enterocolitis or polymicrobial inflammation of cecum, that is typhlitis, both of which can lead to significant rectal bleeding. So when is rectal bleeding seen? In children with HIV or immunosuppression, any kind of immunosuppression secondary to chemotherapy can develop what? CMV enterocolitis or polymicrobial inflammation of the cecum, that is typhlitis, and they can lead to rectal bleeding. The aim of investigation in a child with the lower GI bleed is to localize the site of bleeding, that is small bowel or the colon, and to determine the etiology. The approach is as shown in the table and figure 12.27. Supportive treatment is similar to that of the upper GI bleed, and specific treatment depends upon the underlying cause. Fine. So this is all about, this is something is left. Evaluation for the etiology of the lower GI bleed. So if there is something like colitic presentation, and there is something if non-colitic presentation. In case of any colitic presentation, hemogram, ESR, CRP, albumin, stool examination for the trophozoites, and the culture, and Clostridium difficile toxin. Colonoscopy with the biopsy for histology, culture, and immunohistochemistry, and upper GI endoscopy, enteroscopy, CT, MRI, capsule for the disease extent. And in case of non-colitic presentation, we need to do the hemogram, prothrombin time, colonoscopy, and biopsy or polypectomy if any polyps are present based on the presentation. USG abdomen in case of intussusception, technetium pertechnetate scan in case of Meckel's diverticulum and the intestinal duplication, CT angiography in case of any aneurysmal bleed, and capsule endoscopy or enteroscopy, small bowel source. Fine. So this was all about upper and lower GI bleeding. Thank you.